Okay, so this is not your usual skull-based topic, but I think it's a good way to finish the day. You've seen a lot of innovative things. You've seen how things have changed over the years. And if anybody thinks that they're going to finish their training and spend the rest of their life doing the same stuff every day, well, after about 5 years, you're going to be obsolete. So things change quickly, and you've got to keep up if you want to stay relevant. But it's one of the exciting things about my career has just been how much things have changed and the opportunities for creativity and innovation, particularly in skull-based surgery. And so I think this is a very relevant for anybody in a surgical career. My disclosures for my talk, I'm not going to be talking about any of the companies I've involved with. And in the interest of full disclosure, I did not vote for Trump. I'll leave it at that. And so this you've been through the history already. It all started back in the 1970s with Dr. Eugene Myers, the chair of ENT, and Dr. Joe Maroon, one of the neurosurgeons at UPMC. And based on the seminal work of Smith and Ketchum, they had this patient noted here with an adenocarcinoma involving the skull base. And you see a moulage that was created for fabrication of an external prosthesis. But this shows that the resection that they did, crude by today's standards, but very innovative at the time. And then over the years, there's been a progression from those pioneering days to the era of open skull-based surgery. That's when I was starting my fellowship. Introduction of radiosurgery, as we heard, with Dr. Lunsford. And then in the 1990s, the development of endoscopic pituitary surgery. And then that in the late 1990s really branched out into the ventral skull base in both the sagittal and coronal planes. And so now we're at a point where it's really multi-port surgery. We're approaching the skull base from multiple different angles, both endoscopic and external approaches, and in some cases combining them at the same time. Here, this picture was shown before, but this is me when I was a fellow with the skull-based team, with Dr. Shaker here and Dr. Jonica. And this was at our 25th year reunion, getting everybody back together again. So I've been blessed to have worked with some great teams over the years, as shown here. And, it's been, I think, the key to our success here in Pittsburgh. And, much of surgery becomes sort of cookie cutter after a while. You're doing the same thing. It's like a factory assembly line doing the same operation over and over again. And that has its value. There is a role for standardization, but that doesn't really prepare you for the variety of things that we may encounter. So here's a posterior circulation aneurysm involving the PCA. You can see quite large. It's calcified. And so, every case has its own challenges. You're faced with unknown challenges. You have to be able to innovate to deal with the variety of things that you will encounter. And so this was certainly one of the most challenging aneurysms we ever did. Surgery has been compared to music. The Greek god, or the ancient Greeks recognized this. Their Greek god Apollo is the god of both medicine and music. And so there are a lot of similarities here. It's a performance. It's integrating different sensory and motor information, coordination of eye and hand, spatial visualization, having to react to things and alter your activities on the go. And in particularly, it's been compared to jazz music. There's a great article that covers this. And here we have, different specialists working together, highly interdependent. And just like jazz music, you really don't know what's going to happen next. You're having to read what's going on, what is your partner doing, and making decisions based on that. And you have to be willing to take risks, but also have to have a certain level of trust with each other based on your years of working together. And this is what I like to call traffic jazz. This is from one of my trips to India. And Dr. Gardner and I are in the back of a taxi, and here, 2-lane road with at least 4, maybe 5 lanes of traffic in both directions on both sides. and cars weaving in and out all over the center line. And I'll just move things forward. But this is, to me, this is like surgery. This is like a jazz music performance here going on. Everybody, there are no rules really. Everybody's sort of looking to see what other people are doing and adjusting their activities based on that. And you can see very nicely we're about right behind a flammable truck. Um, and so I was joking this may be the last video I ever take, but eventually we're able to get around this truck and continue our journey safely. So just like music, innovation is on a continuum. Everybody does an operation in their own way, so their own interpretation, and they may embellish it a little bit, but it's still basically the same operation. You may introduce new elements, a variation on the melody, perhaps, and then there's finally improvisation, in which it has little resemblance to the original work. And here are some examples from my own career over the years. And these types of innovations can be categorized according to this article into types A, B, and C. And type A is a response to an acute problem in the OR, something that you hadn't faced before, but you've got to deal with at the time. And so we were doing a reconstruction with a pectoralis muscle myocutaneous flap, and it didn't reach the defect. This was a temporal bone defect. And so I transected the vessels. And fortunately, my fellow at the time, Dr. Costantino, had microvascular skills. And so we did a microvascular free flap with the pectoralis muscle, and it healed fine. So it's the only time I've ever done that, but it solved the problem. Type B is when there's no adequate therapy for a life-threatening problem. Here you see a scan showing a very large arteriovenous malformation filling the clival region in this 4-year-old child. He had multiple embolization procedures for life-threatening epistaxis, was blind in one eye, had lost both internal carotid arteries, and was just surviving off of the posterior circulation. And so we'd never treated a vascular lesion before. Using endoscopic endonasal techniques in 2 or 3 surgeries, we were able to completely eradicate this AV malformation, and the child did fine after that. And subsequently, we've gone on to treat a variety of vascular lesions endoscopically, but this showed us that it could be done in a safe, controlled manner. And then type C, premeditated, but for a very specific patient. And so one of the challenges we had in reconstruction was a large anterior cranial base defects, especially when a nasoseptal flap was not available. And so we were just wondering, well, how can we use the pericranial flap without doing a craniotomy? And so Dr. Zanation and I came up with the idea for the extracranial pericranial flap, where it's introduced through an opening at the level of the nasion, but outside the cranial cavity. And so you can see how there are different types of situations that all result in the same thing, an innovation. And then you've heard us talk about first of its kind epilepsy surgery using an endoscopic transmaxillary approach to resect a diseased temporal lobe, medial temporal lobe, without the need to manipulate or resect normal brain. So, applying what we already know, but to solve a different type of problem. So what is innovation? It is the process of creating value by applying novel solutions to meaningful problems. You can see it's where novelty, value, and solutions come together in a Venn diagram. And if we think of innovation as the cell, then creativity is really the nucleus of the cell. This is what is the spark for innovation. As Albert Einstein said, creativity is seeing what everyone else has seen and thinking what no one else has thought. So a creative person will look around them and see problems all the time. They're everywhere you look in the OR. As a species, why are we creative? There's good evidence, I think, that there's a survival advantage to have highly creative individuals, risk takers in your tribe, and trying new things, new survival strategies, exploring. I think is very adaptive for our species. But these days, it's not so much for survival, but there are rewards in doing creative things. And the people who are most motivated are those where their motivation comes from intrinsic rewards. And so this is really just enjoying something because of the autonomy, the mastery, the purpose. Extrinsic motivation, such as money and awards and acknowledgement, really are sort of false or hollow rewards in many cases, and don't have the same value. And if you're really working based off of intrinsic motivation, you have this opportunity of being in the zone, what's known as flow, by the author Mihaly Csikszentmihalyi. It's a great book on creativity, and I don't know if many of you have experienced being in the zone, of fully immersed in a feeling of energized focus, full involvement and enjoyment in the process of the activity. You sort of lose all sense of time and are really engaged in what you're doing. And many times our surgeries are like that. Well, who are the surgical innovators? There are many great surgeons over the last century, and here are some that have been recognized in the literature as being pioneers and innovators. Our own Tom Starzl, who is the father of transplant surgery in the middle. And you may recognize some of these, some neurosurgeons in there as well, ENT doctors. But if you dig a little deeper and try to understand what makes them different, you can recognize that there are really two types of genius innovators. And this is a fascinating book by David Galenson, an economist, called Old Masters and Young Geniuses, The Two Life Cycles of Artistic Creativity. And he shows that there are really two types of innovators. There are conceptual innovators and experimental innovators. And he looked at all the different disciplines, economics, art, mathematics, architecture, all these different disciplines, and categorized people based on their most seminal work, their greatest accomplishments. And so if we look at some conceptual innovators, these are people who have a big, great idea early in their career. And as an example, the architect Maya Lin, who created the Vietnam War Memorial in Washington, D.C., which is really an amazing memorial, very emotional experience for us. She did this at age 23, and you can see some of the others, innovators, how young they were. Einstein is a perfect example of a conceptual innovator. Experimental innovators, on the other hand, do their best work late in their career. Paul Cézanne, the famous Impressionist painter, you can see did his best work at age 64. And a lot of his works of art were actually unsigned because he was always trying to improve on them. The process was never done. A lot of his works just he weren't finished in his mind. The famous architect Frank Lloyd Wright, one of his most famous structure is just outside Pittsburgh. If you're ever here, I highly recommend visiting it. It's called Falling Water, and he did this at age 70. So if we compare the two types of innovators, the conceptual innovators would be our young geniuses like Einstein, who have a sudden inspiration, sort of a very simple, big idea, and they have a very specific goal of what they're trying to achieve, where they're trying to get to. In contrast, the experimental innovator is the old master, somebody who's working slowly towards perfection. They may be uncertain where they're going to end up, what their goals are, but it's something that slowly evolves over time. And I think there are people who sort of mix both of those or in between, and you may look at your own career and put yourself in one or the other category. I think the important thing is to realize that you're never done innovating. That there's room in this world for both types of innovators. And just because you haven't had a eureka moment like Einstein, there's still opportunity for you to do great things. Great experimental innovators may add substantive content to a discipline, while great conceptual innovators may change the domain completely. And so this has been likened to the fox and the hedgehog. The fox knows many things, whereas the hedgehog knows one great thing. In skull-based surgery, we can divide some of the advancements in our own experience into the two categories. Conceptual innovations include the introduction of open skull-based surgery, which was very radical at the time, and certainly endoscopic and nasal skull-based surgery, which was driven by technology advancements, was a big departure from the status quo. And then experimental, the contralateral transmaxillary approach is not a great innovation. It's just applying what we were already doing in other areas and just applying it to solve a new problem to get to a new area. So building slow incremental improvement. Is there a creative personality, or are there differences in people who are great innovators? Certainly there are differences, generational differences in people as far as how they approach problems. And some of this may be to the way we grew up. I grew up in the Lincoln Log and puzzle era. And these days, everything's computers and virtual reality. So we may be developing different types of skills. It's hard to know. And just like a professional athlete, there may be a critical period of development for some of these creative skills. And I do think there's great value in having hands-on experiences early in life. So I still encourage you to use some of these older toys with your own kids. When we look at Nobel Prize winners, Adam Grant wrote an interesting book called Originals, showing that they were disproportionately involved in artistic activities, particularly the performing arts. Nobel Prize winners were much more likely to be involved in these pursuits. And these also apply to other innovators, entrepreneurs, and inventors. And looking at Albert Einstein's rejection letter for the position of associate professor, his professor said, your assumptions appear to be more artistic than actual physics. But, maybe that was a good thing. The creative personality is quite complex and sort of a mixture of contradictions. I think most importantly is an overriding curiosity. Somebody who's always asking questions. Why do we do it this way? How can we do things differently? Is there a better way to do things? And they also approach things with sort of the child's worldview, with a naive, open mind. And then we'll talk about convergent versus divergent thinking. Creativity is not the same thing as genius, as we'll see. So seeing the world as a child is something we tend to lose, probably as a result of our formal schooling. So what if you were the father here? What would you do if your child got their head stuck in the railing? But leave it up to the child to solve the problem. So this is called lateral thinking, thinking outside the box. And perhaps we can train ourselves to be more lateral thinkers. Divergent thinking is when you think of all the possible ways to reach a final solution rather than sort of going straight to one solution. And I think divergent thinking is very important for solving problems and innovating. And this can actually be measured. You can create a task and look at the fluency or the number of responses, how flexible someone is in producing different ideas, and how original they are. One of the tasks I often do in resident interviews is to say, okay, pick one of these items here. Tell me all the things you could possibly do with a paperclip, and just see, how divergent someone is in their thinking. Here's another example. This is a common ethical dilemma that's used to spark conversations about ethics. But how would you deal with this problem, having to make a choice? Well, this person certainly had a very interesting, divergent way of solving the problem. How does the creative process work? It's not a straight line from start to end. As you can see, it can be somewhat of a tangled mess. But first, you have to get rid of the old ways of thinking. Every act of creation is first an act of destruction, as said by Pablo Picasso, the famous author. Another 17th century poet and samurai described it as, my barn having burned down, I can now see the moon. And that's what happened in skull-base surgery. We had to sort of blow up the old paradigms, get rid of our rigid view of how things could be done. And it was, quite a war that we waged for several years, trying to convince people that this endoscopic surgery was worth pursuing. We often think as progress progressing on a straight line. Is it incremental, little baby steps, or a giant leap? So on the left, you see fossilized dinosaur footprints, and then, of course, man's footprints on the moon. And I think it's a little bit of both. New technology may come along, so there's a sudden jump. But most of what we have done over the last 20 plus years, 20 to 30 years, has been incremental, building off of the discoveries and innovations of those who come before us. And there are times of acceleration and deceleration. It's not a straight line. And we also have to realize that sometimes we have to take a step back to choose a path that gets us to a higher point. So climb back down the mountain and go back up to get to a higher peak. And that's the way it was with endoscopic skull-base surgery. In the first few years, we had a very high leak rate, as high as 40%. There were a lot of problems we had to solve with technology, with reconstruction, with hemostasis. And so, we had to put up with a lot of criticism in those early years, understandably. But it's what was necessary to get us where we are today. The creative process actually goes through multiple stages. It's not just one leap. There's sort of a preparatory phase where you're thinking about things and incubating an idea. You may have a sudden insight into how things could be solved. You evaluate that solution, elaborate and build upon that, and then the process starts over again. There are necessary ingredients for creativity. You need a base, a sound base of knowledge and technical skills to innovate. As Charlie Mingus, the jazz musician, said, you can't improvise on nothing. You got to improvise on something. And so we can't just look everything up on the internet. There is a necessity to have some funda knowledge, some basic skills that are part of our brains. There are lots of books on innovation. This is one I think that's very useful, describing the catalysts of innovation. And these are questioning, observation, associations, networking, and experimentation. So innovators are always asking questions, as I mentioned before. They're curious individuals. They're acute observers, seeing things that others don't see. They're always analyzing a situation, just like Sherlock Holmes, this famous detective would, looking for associations between different disciplines, different specialties. There's great value in walking into somebody else's OR, even if they're in a different specialty, just to see how they solve problems. What technology are they using? Can you bring that back to your own place of work? Networking, getting outside of your bubble, talking to others, whether in the same or different specialties, once again, looking for new ideas. And then finally, experimentation, trying your ideas out in small experiments to see what works and what doesn't work. And so I've created a little mnemonic here for you, Quone, to help you remember the catalysts of innovation. Observation skills are very important. As surgeons, we develop pattern recognition skills. What do you see when you look at this picture? Can you make sense of this? There's a cow hidden there. And so that is a skill that we can sharpen. Amy Herman wrote a wonderful book called Visual Intelligence. She is both a lawyer and an art historian, and she used her expertise in art history to really help train people to be better observers. And she's done a lot of work with law enforcement, teaching them to read a crowd, read a crime scene, to see things that others may not see, to anticipate and find problems before they develop. And she's also worked with medical students to improve their visualization skills by having people study works of art and really take, spend 20 minutes looking at a single painting just to capture all the information that's there. So the same thing applies in the OR. That's the difference between a novice and an expert surgeon, is the ability to quickly look at the visual environment and make sense of it. To be creative, it's helpful to have a creative environment, one with good mentorship. As we talked about in Pittsburgh, we had good leaders with vision who gave us the freedom from dogma to pursue these new ideas. A culture of innovation where there's a free flow of ideas across disciplines, support from your family and colleagues, and also the necessary resources to do the work. Aesthetics can be important. You could have a nice mountain retreat or just go on long walks. Here you see Albert Einstein on the Princeton campus on one of his many walks with a physicist. Especially being out in nature, it's a time for reflection. Semi-automatic, or what we call autotelic activities, are a great way to let your mind run free. So going out for a walk, for a jog, bicycling, driving your car, these are all things where we can, we don't need to be thinking about what we're doing necessarily. And then you can, in your own microenvironment, you can create a more creative space, personalize your own office space, improve the feng shui, so you have a more creative environment. On the dark side, there are inhibitors of innovation. Certain cultures do not tolerate risk and want conformity. There may be a high price for failure, not receptive to change. And so you've got to be in the right place or develop the right culture. It's very hard to go into a place and change the culture, however. If you're too super specialized, you're really not going to have the diversity of observations, of experience, and networks to really innovate. You may lack resources. Of course, there's a need for oversight and regulation to make sure we aren't doing things that are unsafe for our patients, but it's possible to have too much regulation. And then we certainly need to be careful about conflicts of interest that would encourage us to take chances with our patients that based on our own activities. You can maximize your creativity in a lot of ways. This is sort of the take-home message. Be curious about everything, reject the status quo, discover other domains. As I mentioned, take time to see what other people are doing. At your next meeting, walk into a lecture hall on a topic that is not really relevant to your practice and see what they're doing. I just went to a society meeting that's outside, other than otolaryngology, and learned a lot of things just by seeing what other doctors were doing in another specialty. Network within your field, shape your space, and control your time. And if possible, create flow in your activities. That's one of the joys of working with my skull-based team here, is I think we're creating flow every day in the OR, not just CSF flow, but I'm really enjoying our activities, innovating, solving new problems. Excuse me. So where do we go from here? I don't want you to think that everything that can be done in skull-based surgery has already been done. There are some new surgical approaches that we haven't talked about today. They're still under development. New technologies will come along and push things in a new direction. So you never know where things are going to go. Here are just a few areas that I think are areas for innovation. Of course, we will continue to develop new surgical approaches based on better understanding of anatomy and as well as new technology that enhances our ability to do things. Excuse me. Just getting over a cold. Visualization technologies are really the platform for surgery, especially navigation. Virtual reality will certainly become the norm in the future. And I think that's where most of the intraoperative changes are going to occur. Robotics is inevitable. It is making gains. It's a slow process. It's not quite ready for skull-base surgery yet, but certainly we will be seeing more robotics within our specialty. And finally, there will be new biologics for reconstruction that will greatly enhance our ability to repair large defects. And I'm just not including all the non-surgical innovations that will occur, better therapies for our patients so that we can avoid surgery altogether. I hope this lecture has been of interest to you. And this was an address I gave at our NASBS meeting when I was president of the society. And so here's the citation for that publication if you'd like to read about this more. But I encourage you all to become innovators and take the time to really develop your own skills and look for unsolved problems in your own area of work. This has been a wonderful conference, and I'd like to thank our colleague in London for putting this together. It's been a pleasure speaking to you today.
Thank you so much. That was fantastic talk to finish off the day. We've really enjoyed visiting Pittsburgh and seeing what's going on there. There's a fantastic range of surgery and great training program that you guys have organized there. It's a real inspiration to everybody who's been watching today. So many thanks to you and the team there.
Thank you so much.
Thank you, Professor Snyderman. And as we come to the close of today's incredible journey, more than 7 hours of discussions, insights, and shared learning, there could not have been a more fitting finale than Professor Carl Snyderman's thought-provoking talk today. His exploration of philosophy behind skull-base surgery, he touched on creativity, innovation, and the evolution of our field. This has given us much more to reflect on beyond the technical aspects of what we do. So, Professor Snyderman, your ability to challenge conventional thinking and inspires us to push boundaries is what makes you not just a pioneer, but a true visionary in skull-base surgery. On behalf of Kathy, my co-host, and all of us here today, we thank you for sharing your wisdom and for leaving us with ideas that will continue to resonate long after today's event. It has been a privilege to have you with us.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.